something when you're live.
Meeting is being live streamed.
There we go.
Hi guys, thanks for watching. This is Essence of Medicine, the history of Trans-Kambin OLLIF. I'm Amanda Armagost.
And I'm Dr. Abbasi for Essence Podcast. Being live streamed.
And I'm Dr. William Talley.
Hi guys, thanks for watching. This is Essence of.
So, this is truly my privilege, to have you on our podcast. About 2 weeks ago, I was talking to Ken Barra, who is an engineer. I'm sure you remember him, who was involved on the engineering part of developing the Trans-Kambin OLLIF. But for many of our viewers, this might not be a term they are familiar with. As a matter of fact, many of our viewers may not even know what the spinal fusion is. You have, first of all, give me a little story, your background, your education. Who are you and why your information is important?
That's the essence of life, right? Figuring out who we are. I'm from North Carolina. I'm currently practicing in Athens, Georgia, in a orthopedic subspecialty group. I ended up in Athens a little bit circuitously. I went to college in North Carolina, did med school at Wake Forest. I did some graduate work at Duke at the same time, and then did residency in both neurosurgery and orthopedic surgery at Thomas Jefferson in Philadelphia, which is now the Rothman Institute, which a lot of people have heard of. Then subsequently did a fellowship at Penn in complex spine, and then went into private practice down in Savannah, which is where a lot of these people ended up coalescing around the same ideas. And I have no doubt that Dr. Abbasi will understand this. I went to a program where no surgery was too open, no incision was too long, infections were expected, blood loss was just part of the game. And that's great when you've got residents and fellows to deal with all that stuff. And when I got into the real world, I got really tired of dealing with those things left and right. None the least of which spinal fluid leaks, the headaches, all the stuff we pretend doesn't happen, but we know does. And that's kind of where I am now. How I ended up in Savannah, my thought process was starting to change and looking for better ideas. And one of the things that was coming along at that time heavily was lateral. And so I started thinking outside of the box of my training, outside of PLIF or true posterior interbody.
But
and looking
before
at,
we go to the laterals and so on,
yep.
For many of our viewers, maybe a spinal fusion is a term they are not exactly familiar with. Now,
sure.
Now, first of all, you're very accomplished. How long have you been practicing?
I've been doing spinal surgery only for 15 years.
Only for 15 years.
Yeah.
Now, explain that, in what situation in spinal fusion is a surgery of choice in your hand?
Wow. Okay. So that's a great question. And it's a question that's evolving rapidly and deeply. When you think back on the time frame of what our opportunities to intervene on patients, traditionally it was washout infections, do a laminectomy or cut away stuff to make more room for the nerves, and then hope that what was left was stable and strong. And that's where we got a lot of bad names for ourselves back in the 90s, 80s and 90s especially. And so the way I think about surgery today is it's not deconstructive, it's constructive. In other words, as the spine deteriorates, we can, the analogy that I think about is that's like your closet's getting full of stuff as you get older. You got 30 pairs of shoes and 12 pairs of pants that you haven't even seen in 20 years. And then the next year you got more of that. And the next year you've got more of that. And then all of a sudden when you walk into the closet, you don't have room and you're unhappy. Well, that's a nerve. Okay. It's unhappy. The traditional surgery was let's go into that closet and start throwing things in the garbage to make more room for more junk, right? Scar tissue, more aging, et cetera. The paradigm shift that happened with OLIF, as we're here to talk about, but also a couple of other techniques, was rather than going in there and throwing away clothes, why don't we push the walls of the closet further apart? Why don't we make a little more room in that closet?
That's a great analogy, Bill. That's a great analogy.
The second part of that is, if you're not a contractor and you don't know how to build walls, that sounds like a horrible surgery. Let's go in there and move things around. Oh my God, that's terrible. But the synergy between the new implants, the new imaging, the new navigation, it's actually now easier to move the walls than it is to throw stuff away.
Yeah.
In my opinion. Plus, I've got a more stable structure, and that's how I explain it to patients. I haven't come up with a better one than that, but I do think that's reasonably good. And so that's where
that's a great analogy, and to practically, I use a very similar analogy. I say I will restore the height of the disc to the point where you didn't have the symptoms by putting something between and lifting it up. And I want the viewers know that you are not just an expert on OLLIF. You said you have been practicing for 15 years, and you talked about some others. I'm sure you see my screen that I'm sharing right now.
I do.
And so, explain the surgeries that in this list that you perform, and I will point to that for the viewers. Please go ahead.
Oh my gosh. Okay, so I do all of these at some point or another. And the beauty of having all the arrows in your quiver is I know which arrow to use on each individual target.
Yes.
So the way you have your slide laid out here, the 12 o'clock position PLIF, that's more or less the great grandfather, I guess you would say, of fusion. We were just doing screws back in the 80s, and that didn't heal very well. And it gave us none of the benefit that you're describing, which is to push the bones further apart, make more room. Mm-hmm. We were just trying to make things stiff. But the interbody concept from mostly Harms, but a few others, allowed that reconstruction. The problem with the PLIF is we got to move the nerves. We got to come in straight from the posterior aspect or the back of the spine. And there's a lot of squishy things in the way there that don't respond very well to being moved around. And so then the idea of let's attack this spine from a different angle, and what limitations will we run into with each level of the spine, so L1, 2, L2, 3, et cetera, based on the local anatomy. The way I think about it, the perfect surgery is coming in from the front. We do that in the neck all the time. Mm-hmm. Right. It's ACDF is probably one of the top 5 most successful surgeries performed on humans. And the reason we do that is it's easy to get there from the front. We can get there almost as easily from the back, but then we dissect all the muscles out. The patients are miserable for 3 months. Mm-hmm. And so if we can come in from an angle where we don't have to cut as much soft tissue, less damage, but yet get the same restoration, then let's stop going in posteriorly. Let's look at angles, either TLIF, as you have there, or transforaminal lumbar interbody fusion, which is a little bit of an offset approach, but still posteriorly. And then as you go around the clock, OLIF is an intermediate between the transforaminal and the DLIF or XLIF or LLIF or whatever trademark term you want to use there. Which is coming in directly from the lateral through the psoas muscle. There's now also an anterior to the psoas approach, which is down in your, that's the psoas muscle you're just showing. So anterior to that, so we do a little bit less dissection. It's a little bit trickier to get the reconstruction. So it hasn't had as much commercial success as I think Medtronic wanted. But then there's a workhorse of ALIF, which is a great surgery, phenomenal outcomes, but has some significant anatomic limitations and risks associated with it.
And I want to emphasize there that I as well has performed all these surgeries. As a matter of fact, in 2012, my workhorse for many of my patients was ALIF. And I tell to many of the people who are involved in that, if I wouldn't have moved from my first place to my current place, I would not have been getting on board with the OLLIF, because ALIF worked so well with me because I had a surgeon would give me access in 15, 20 minutes.
Yep.
ALIF, you have a general surgeon or a vascular surgeon that open up your belly, is familiar with the anatomy, and there are major vessels there. Now, I am not exaggerating to say that in 2022, and will be the same in 2023, people still die of this surgery.
Yep.
If it's not done properly.
I think of ALIF as juggling chainsaws.
Yes.
When it goes well, everybody thinks, "Ooh, wow, that was cool." And when it goes badly, it's ugly.
Yeah, it is ugly because when I moved in 2012 to a new place, the surgeon who was helping me needed 3.5 hours to give me access for.
Yeah, it's impossible.
And that is no different in some places in University of Minnesota and big places here. That has not changed in the last 10 years. So if you have a good team, this is a beautiful surgery. I love it. But if you don't have a right team, because
Yep.
there are so many smaller vessels in funny locations, especially vessels that go in the bad area behind the well, behind the veins and so on, and that can turn ugly. In this town, somebody has to be transferred from a surgery center to the hospital with the surgeon hands in patient's belly,
Yep.
and that makes this surgery a hit and miss. But it's a beautiful surgery when.
Yeah, I think your point is spot on. If you've got the right infrastructure and you've got a vascular or general or trauma surgeon who understands what you need and only what you need, and they're efficient with their hands, it can be slick.
Yeah.
I had to, when I moved here to Athens, I had to get that system in place, and it was amazing to me how differently they look at anatomy than we do. And the idea of control and exposure. Fred Simeone used to say, compared to one of the other neurosurgeons there who wanted to see everything and control everything. And Dr. Simeone just passed away, sadly, but he was a great man. His comment was, "I know there's a tiger in that bush. Why would I stick my finger in that bush?" And
but
so
the tiger is there. The tiger
yeah, right.
waiting.
So I don't need to go find it. I know where it is. Leave it alone, right? And I don't. To your point, a lot of the vascular surgeons they want to go find all the tigers, and we don't need to see them. All I need to see is L5S1.
Yeah. So when I was in 2012 in the new place, I knew I cannot do ALIF anymore because.
So your drive was logistics as well as
Yes.
kind of thought process.
So
I got you.
I was looking for alternatives.
Gotcha.
And I
Yep.
was lucky. I went to a place and I saw this handsome surgeon.
Oh my God.
12, who literally opened my eyes. And literally, this surgery was 10 years ago. This is you. Well, you're doing a L5S1 OLLIF. Few things that people need to know. First of all, I have been trained for 13 years. I did a half residency in Germany, then in United States, in most of the important institutions. I have been in Stanford, in Dartmouth, in Houston, in MD Anderson, every place. I have been trained under 150 surgeons. So this is truly a compliment when I'm telling you, well, that day, even though I was an accomplished surgeon, my jaw dropped on the floor. And
I appreciate
because
that.
I saw something that would take me 2.5 hours. You did it in under 1 hour. And I watched that patient walk out of that surgery center. I watched myself walk that patient walking out of the surgery center within few hours. And for regular people, that may not mean much. But for people who do what you and I do, that is an extreme accomplishment to watch what I was. So my eyes were open. I was in shock and awe that what did I observe? What is going on here? Can you tell a little about your involvement at that point?
Yeah, be happy to. I want to say one thing about that. Was very kind of you to say that. The ability to do that surgery, I appreciate you recognizing that and saying it. The one thing I'm going to say before I talk about how we got there is you did the unusual and correct and brave thing of, instead of listening to a talk by me or Randy or somebody and then going, there's no way that's true, this guy's crazy, he's killing people, there's no way he's doing it in the surgery center, you said, okay, show me. And it was very surprising to me, and remains very surprising to me, how few people are willing to go and actually watch somebody else operate. They'll go to a cadaver lab, they'll go to a sawbones lab, they'll watch a video, but to actually take the day, travel, and then go watch. And people like you actually inspired me to do that more as well. And there's huge benefit to that. So congratulations, I guess, on being brave and looking outside the box, and thank goodness our box had something of value in it. In terms of the surgery at that point, I guess that was 2012. So I'd been here in Savannah for about 2 years. We were just getting our feet under us to do that surgery in the surgery center, because when I came from Savannah to Athens, nobody was doing outpatient spine surgery. And so there was a tremendous institutional momentum against me. And it took a couple of years. So you kind of arrived at the right time, I think, in terms of the calendar. And so we continued to develop the technology and continue to develop the technique and make things more streamlined and efficient. So you kind of were introduced to it. We were right in our stride.
Yeah, that was, by the way, May 24th, 2021, and that I observed that surgery. So you were setting it up, and you're absolutely right. I think if I would call my blessing, I didn't say, when they told me that what you do, I didn't say just nonsense. I said, nonsense, I want to watch it. I want to see it, because I don't believe it. Because why would it be unbelievable that if 10 years ago, actually, somebody told me that I know a doctor in Georgia doing this surgery while I was in the surgery, doing the same surgery, does it under 1 hour in a surgery center. Why would something like that would be unbelievable 10 years ago, even now? And
right.
That is the point. It has not much changed in the last 10 years. We still have those people who just say nonsense and move on.
Yep.
Why would that be unbelievable? What is about that unbelievable to them? What do you think?
I think the way for me to answer that question is, when I don't do a tremendous amount of teaching anymore. I had some other interests come up, but the one takeaway I had was there are two kinds of people. There are people who get educated or trained. Let me rephrase that. There are people that get trained, and then they spend the rest of their career explaining to you why they do what they do is because that's what Hippocrates told them that they should do what they were. And then there are people that get educated, and they go out into practice and they keep getting educated. And I think what we're seeing in the spine world is this. It's the people that are thinking and looking at what's better. And they're the people that stick with, I know this is what's going to happen. I know this is predictable, and I'm going to stick with that.
And that is not new.
No, I think that's human nature.
I read lots of books, and one of the most advantageous thing that happened is in Renaissance, that they said Aristotle was wrong.
Yep.
And practically it took them almost 2,000 years. They just said Aristotle said that, and that is what it is.
Well, once you take the moral argument away from it and just look at the facts, and it's easy to villainize someone you don't agree with. And I think that happens a lot in medicine because of the medical legal concerns and the egos.
Yeah.
And so, there's a huge number of people that are doing innovative stuff. And I like you, have always tried to say, well, if Tony Young is telling me he can take a disc out through the foramen, I want to see it. And those are the things that drive this. And fortunately, those things happening have really changed what spinal surgery is now. I mean, it's not something you survive anymore. It's something that you go get because you want your life to be better.
Now, Will, I want to show you a picture, and I tell everybody, one is open surgery, one is MIS, and it's not about the skin incision. It's about what happened under the skin. All the time that we don't spend to cut the muscle, cook the tissue. You talked about the risk of infection, which is for open surgery, for TLIF, PLIF is considered 3 to 5%.
Yep.
My risk of surgery infection has been 0.17. Yours has been probably very similar. So 1/20th risk of infection. People stay in the hospital much shorter because we don't damage those muscles.
Yep.
And all of that, we see the result of that. As a matter of fact, one of the reasons I started really getting on board and doing more and more of this is because I saw the result to my actual patient.
Perfect.
And
Couldn't say it better.
yeah, but in your hand, what was your involvement? This is about your view of how this development, because you are one of the main people who actually developed this. Many of the tools that I'm still using, they were your ideas. So tell me about all the background took you from before to make you in 2012, May 14, to perform that surgery in 1 hour. People don't understand how much work it takes to make
right.
that happen.
The exposure, like you see on the left there, now that's a magnificent example of a scoliosis surgery. And that's not a minor degenerative single level outpatient surgery. That's huge, but the techniques are exactly the same. It's a la carte. And so on your right-sided slide, you show that same major surgery done, minimally invasive. I want to step away from the dramatic example you have there, although that is accurate and quite telling. And imagine if we're only seeing 4 of those screws. So the incision's a lot smaller and it's not as brutal looking. But to your point, how big the skin incision is not the story. It's like when you run your car without oil and the engine blows up and you look at it from the outside and go, well, it doesn't look that bad. But what's happening under the hood is pretty awful. Yeah. And so kind of hard, bringing back what I said earlier, I was getting tired of all the complications that we were dealing with because they're not acceptable, right? They are reality, but they're not acceptable.
Because we can do better.
We can do better, exactly. And everybody that I talked to had this idea of anything that we do has got to be perfect. And I'll use the lateral approach, which was heavily criticized by the OLLIF approach proponents because they were getting some transient nerve injuries and transient neuropraxias or painful nerves. And my argument when I was teaching that was, are we comparing this to perfect? Or are we comparing this to what our actual alternative is? And the actual alternative is an OLLIF in which people die. Now it's a little dramatic. They don't die left and right, but it does happen. And when I made that transition in my head, OLLIF made a lot of sense because it's not perfect. Nothing we do is perfect. Anatomy is variable. Humans are variable. But the complications are so much less, but they're slightly different. And you have to be willing to step off of one rail and onto another rail and realize that's a better rail. And so to that point, we were looking at the amount of work it took to do the dissections out. I will say the advantage of having an open training was seeing all that anatomy from so many different directions, being able to turn that into a 3-dimensional model kind of in your head of what am I looking at if I just see an X-ray and I see one piece of bone, and then developing the idea of let's use the instruments as tips of fingers to understand what we're touching. Does that correlate with the X-ray? And then, of course, a big part of that is X-ray, being able to have biplanar fluoroscopy. That was something that was not common or even really used very much. And so
Bill, I want to show something here that I think is a very crucial thing. You are working, your hands are in one place, but your eyes go back and forth somewhere else. Most people don't recognize how tremendous amount of rethinking that requires because we are trained. You open, you look at the anatomy, you make a 3D model of the anatomy in your brain, and then you adjust your instrument and you are a millimeter away from spinal cord, major vessels. I'm a millimeter, for people who don't know, that is like a 25th of an inch. And you have to do it again and again and again, tens of thousand times without, having a complication. And now a general surgeon went through the same process. When they were going from open surgery, as a matter of fact, I interviewed a general surgeon. Their transition from open surgery to endoscopic was very painful process as well. It took them 20 years. And he was involved in that, was telling, and that idea that you are doing the procedure and then you turn around and you look at the films, your hands and eyes are not in the same place. This is not a trivial task. Many of our surgeons are really scared of that, but you were brave enough to make the transition. Now,
I would say the opposite. I wouldn't say I was brave. I would say I was afraid not to use the X-ray to confirm that what I was seeing is what I'm seeing.
Yeah.
And so I always joke and say that the reality is I'm lazy and I'm a chicken, which is why I'm always looking for a quicker, safer way to do it.
Yeah, that is actually you have a point. That
I think actually didn't.
It is better. It is.
Didn't Bill Gates said that? He's like, any job I have to do, I hire a lazy man, but they'll figure out the best way to do it. Right?
Yeah.
He did say that.
To compare it about those surgeries, we talked about the risk of bleeding, infection, and so on. But a one-level fusion in average in the United States is about 3.5 hours.
Yeah, I
think 2.5 to 3.5 hours. They published in 2016, the University of Minnesota and Mayo. They had a neurosurgery association here in Minnesota. They presented a paper. Average for the BMI below 35 is 3.5 hours, and above 35 is 4 hours and 20 minutes. Yes, they have to train residents, so that adds something.
Right.
But what you're talking about 3.5 to 4.5 hour surgery, and hospital stay is still. This is public information in Minnesota. For a similar surgery, the average hospital stay is about 3.8 to 4.2 days. And
I just want to ask something for people that aren't medical. What is the difference between a 1 hour surgery and a 3 hour surgery for the patient?
Well, what is that?
Oh, it's huge. So the way I think about it, nothing good happens in the OR, right? You're under anesthesia, a machine's breathing for you. You're basically physiologically dying, and anesthesia is preventing that. And on the one hand, pharmacologically, physiologically, I don't want you under anesthesia. Number two, especially with the more open surgeries, the more soft tissue exposure there is, that's more time for bacterial contamination, that's more blood loss, that's more fluid transitions. And not for nothing, if you're spending that much time doing a surgery, there's only so much disc, there's only so much bone that you can see and move around. And so what that means is you're moving a lot of instruments in and out. Mm-hmm. And every time an instrument goes in or out, that's a chance to hurt something, pull something, damage something. Then the probably the biggest issue is retractor time, right? So it's become very clear that on all of these procedures, the number one variable that drives nerve pain, nerve injury, neuropraxia is how long the retractor is in place. How long is that nerve pushed over, pulled over, twisted, whatever, however you want to visualize it. And so it's no one of those things that makes a quicker surgery better. It's all of them. Yeah. And it's a synergy. It's not 1 + 1 + 1 = 3. It's 1 + 1 = 4. 1 + 4 = 7, because it's cumulative to the body.
And it's amazing, Will, you're just reciting the statistic right now. And this is a study based on almost 400,000 patients. Just the time under anesthesia, independent of kind of surgery, is an independent factor of morbidity, mortality, complication, and so on and so forth. And that relationship is practically up to 3 hours linear. After that, it becomes exponential.
It's exponential, yep.
Especially in elderly, defined 75 years and older. As a matter of fact,
absolutely.
This odds ratio is that every additional half an hour under anesthesia adds 17% to the combined risk of the surgery. And surgeries that are less than 2 hours, if you put them in one group, surgeries that are more than 2 hours in another group, you're doubling complication. And that truly upsets me. And
that's only major complications. That doesn't include delayed mobilization. That doesn't include late DVTs, all the other stuff that comes along with laying around. And it's funny, I got suckered in to a trick question by one of the foot and ankle surgeons, and it always stuck with me. He said, I think we were doing an ankle fracture, and he said, "So what is the ideal tourniquet time for a bimal ankle fracture?"
0.
Exactly. I'm like, well, you really want to be under 25 minutes, right? And he goes, no, 0 is the ideal time. Nobody can do that though. And it's funny you say that, because that stuck with me, that, why would I do something that just that extends the time of whatever we're doing? And then obviously there's financial and logistical concerns as well, but the real issue is patient safety and outcomes.
Yeah. And, and truly upset me when some of our colleagues, still in 2022 or 23, I don't believe the change of year has changed their mind. They think time doesn't matter. I mean, you need to talk just to the random anesthesiologist. As a matter of fact, I have conversation with anesthesiologists where they say on the camera what it makes from their side to extubate the patient, especially larger patients
absolutely
have comorbidity. But it is amazing to me that they look at the sky and they say the sky is green, where sky is blue.
Right.
Physiologists can tell you that longer anesthesia directly impact, and then when they cannot compete, when they cannot have argument against that, then they say, but rushing the surgery is dangerous. And
so I think you're hitting the nail on the head there. There's always two sides to every explanation, right? And I always look for which of the explanations is self-serving. And if you've got a surgeon's ego and you've got a surgeon's mentality, if I'm doing something in an hour, that makes it easy. If I do it in 4 hours, man, that was a real surgery. That was complicated. Right.
Yeah. So tell me about your involvement. You built this
with OLLIF.
Yeah, I mean, tell me about your first view, how you developed that, and you can mention the name, because truly I want this to be a record for posterity.
Sure, I appreciate you doing that too, because it was a group of people that did it, and you've already mentioned Ken Barra. He was instrumental. I would say probably, I was thinking about this morning. I would say probably the nexus point was me trying to compete with Randy Bishop on how quickly I could do stuff. And for those of you that don't know, Dr. Bishop is a neurosurgeon down in Savannah who is an incredibly accomplished technician and a good businessman. And so he was always looking for a way to do things outpatient and a way to do things quicker and more efficiently. And I was in competition with him in the same hospital, and I would scrub in with him to watch how he does stuff. Because he was so quick and so efficient at it. And at the same time of trying to be quicker, but also trying to get away from the complications we were having and having conversations with him, we were both talking about there's got to be a better way to do it. There's got to be a better way. The anatomy is amenable to coming in from different angles. And so a conversation with him that evolved over a few months really was, let's do a TLIF, but let's move over just a little bit more and see if we can.
Like a four lateral approach, or?
Well, through Kambin's, right? Yeah. Because technically a TLIF is a Kambin's exposure, but you drill away all the bone.
Yeah.
So what prevents us from just slipping over a little bit further to the side and sneaking in at the same spot at a slightly different angle? Well, first thing is, what instruments am I going to use, right? Because we've got all these opener channels. And then the second thing is, are we sure we can actually do that? And so it was kind of a synergy between looking at what some of the endoscopic people were doing and recognizing that they were getting there safely.
Through Trans-Kambin approach.
Through anatomy preserving Trans-Kambin triangle approach. So they've already kind of proven this is possible. In fact, I didn't even know this. Do you know where Purvis Kambin worked?
Purvis Kambin, actually, I talked to him 9 months before he passed away.
Oh, wow. Good for you.
And Purvis Kambin, for people who don't know, is the Trans-Kambin approach come from the name of Purvis Kambin, who's a Persian guy, orthopedic surgeon in Philadelphia. And,
so even more, do you know where he did all that work? And I had no idea. He did it at HUP at Pennsylvania Hospital.
Yes, in the
So
United
that's where I
States.
trained, and I had no idea who he was.
Yeah.
That's what a man ahead of his time he was.
Yeah, but when we are talking about Trans-Kambin, we have to as well really give him credit for what he truly did. And I'm just going to Google his name, show his face, because I think his face belonged to this podcast. And you know his name, Trans-Kambin. Kambin is a Persian name, means seeing the advance, seeing the
I did not know.
What a fitting name for him.
Yep.
And he passed away about 1.5, 2 years ago. At
I was
the
going to
age
say it's
of
about 2 years ago.
90. Yeah. And practically, but his development was neglected in the United States. It went all to China, South Korea, Japan, and 20 years later, it actually 25, 30 years later, when Japan, Korea, China were way more advanced than us, it came back to us.
It came back.
It is like the electric car. We made it in here in the United States, but we shut it down. We didn't really use it. It has to go to East Asia before it comes back. So
it had to go where some people were willing to be innovators. I think one of the most amazing things about him is the idea of doing something is, relatively speaking, easy. Why can't we just come in at this angle? But when you're starting with, you're looking at the idea of a screw, and you don't have a screwdriver, and you don't have a milling machine. You can't make. Where do you start? Okay, great. We'd love to go to the moon. How do we? What's the first step, right?
That you're the brother right here, right? Yeah. Now everybody gets on an airplane, but you have to make just some ropes and some piece of wood.
And that's what I was getting at. You know, he did all of his. That's where I was headed. He did all of his work with rigid cystoscopes when they first came out. When the lenses were first good enough to be able to actually see something at the end of an endoscope. The first endoscopes were rigid cystoscopes. He actually did his first surgeries with urology instruments, which is, I mean, to me, that's the epitome of innovation.
Well, I can tell you from what I have heard, you repeated that process in 2010, 2011, the same process. You are the brother right of that in that sense, because I talked to Trans-Kambin, and he explained to me how he developed that, what the problem were, what instrument he used, and so on. But he told he could not have believed that anybody could have done a fusion through that thing. He was amazed at how much farther we have taken that. He have heard of that, but he didn't really know of anybody doing fusion when I interviewed him. That is a few years back, obviously. But from what I hear,
that's very cool.
You actually re-innovated that, and you sitting on the as Isaac Newton said, you were standing on the giant of shoulders, but then became expert in that by pushing the envelope. So Kambin triangle. You were talking to Bishop about how to use this to safely go in, and more than what endoscopic people do. You wanted to place a spacer to lift it up. You wanted to put screws. So please, I apologize. Go ahead.
No, that's fine. I love what you were saying there, and I appreciate you giving me credit. I wouldn't say I was as brave as he was, because he'd already done it. We knew it was doable. That changes everything. But basically, what we were looking at was, do we need to be doing massive decompressions if we do stabilizations? And OLLIF data suggests no, you don't. How many MRIs have you seen after ACDFs, and there's still some foraminal stenosis, and the patients are doing great?
Exactly.
And there's a person that's not involved with this project, but who gave me a mantra that I live by. His name's Dan Cohen. And he said a 65-year-old female comes in with a spondylolisthesis, or a translation at L4-5. She's had back pain for 4 years and leg pain for a year. In my training, it was go in there, open everything up, make sure that nerve's got plenty of room. I want it to be the size it was when she was 15 or 18 or 20. And I tell you, Dan said, why would we do that? We know if I stabilize that slippage, I don't need to correct it. I just need to stabilize it, and her back pain's going to get better. And all I need to do is give that nerve the same amount of room it had a year and a half ago when she was fine. So why don't we do just enough to get the symptoms under control? And I've always stuck with that. And that led to the part of the conversation with Dr. Bishop was, how much decompression do we really need to do? And how much is too much? And so along the same time that idea is brewing, this idea that maybe if we can just distract a la an ALIF or an ACDF, open up the closet, make the walls bigger or further apart, and then do the stabilization safely, do we really need to be drilling off all this bone and doing all this soft tissue damage and blood loss and
that was 2011?
No, that was let's see. I'm going to say that conversation started in 2009, and then I left Savannah right about the time the first prototypes were coming out.
Okay.
And so I was here in Athens in 2010 was when we started doing OLIFs. I think we had done maybe a couple of dozen before I left at the end of 2009.
So what was that process like? For people who don't know, we surgeons, we don't have 40 hours a week kind of work schedule. So you have to do your clinical work, everything else, and on the side, you meet with people. So tell me about that process. You talk to Bishop, you guys come with this idea and so on, but you still have to have the tools. That process. Tell me about that. How did that? Well,
that's the fun part, right? If you enjoy development, that is what part.
You are who you are, because for you that is fun.
So I guess Randy and myself are very similar in our ability to think about what tool do I need to reach around this corner and over that blind spot. And so he had already been working with Amendia at the time on his posted screw system. And that's how I was introduced to Ken Barra and the engineering team there. And who said what in what order, I don't recall. It was really more of a free-flowing discussion. I know the idea of the wire came from the endoscopic localization, and then the serial dilation actually came from the concept of lateral dilation and opening up and coming in by slowly expanding the soft tissue envelope. And then my comfort level came largely from doing a fair number of laterals and realizing how much you can move nerves around. And one of the neurosurgeons I trained with, Mike O'Connor, he used to say the difference between a good surgeon and a great surgeon is knowing how hard you can pull on something without getting in trouble. And the truth of that is, what we realize is, as long as you do it gently and not for a tremendous amount of time, you can move the nerves around safely. And so all of those kind of synergize together at the same time with this idea of let's build an implant that not only is a structural member, it's also a tool.
Yeah. Now, from my conversation with Ken Barra and some previous, you and your group, very small group, you're talking about less than a handful of people. You guys get together, you come with the concept, but the tool for that, they don't exist really. You guys put the tools together. Engineers build that, but you know how engineers build things. They work best in a lab, on a sawdust model, but then in the environment of the OR, there's tremendous amount of the innovation that you have to do to make that work. And then you go back, you ask them to change it so it works better. How long did that process take from the idea until you had a set of instrument to do your first case?
I think we had, we pretty quickly came upon the idea that the implant itself is one of the instruments. And once we made that step, everything else fell into place pretty quickly because it was pretty linear on what we needed. I need dilators, I need wire access, I need a way to impact this. And then I did, I think I probably did about 10 OLIFs.
When did you do your first OLIF?
It would have been early 2009 when we did the first approach. And what I did, honestly, was big incision, open everything up, right? Take the retractors out, put the guide wire in, like we would under
all Trans-Kambin.
So midline exposure, all the anatomy's exposed.
Oh, I see.
Then take the retractors out, let everything come back. Then come in Trans-Kambin, then put the retractors back in. And that's where the pictures that were in that first talk, that's where those came from. And I did that probably 10 times with Randy scrubbing in. And we showed that this is what we're seeing. This is what I'm feeling. And it was a pretty fluid conversation over a few weeks with the instruments that we need to be able to work around that.
And I want everybody who listens to that to know that that is actually how the innovation in medicines are done. You do something that you're familiar with, you know it is safe, and you change small little thing in that process. So, and you know all your ways of backing up from that. You know all the things that can go wrong, and you are in control of the situation. But once you are familiar, once you know that those steps are working, then you get rid of all the unnecessary steps and then move to the next step. So you are just describing, and whereas engineer, they can just break down everything and build it from scratch. We are like evolution. We have to build on something that already exists.
People tend to, they talk about like industrial revolution, technology revolution. It's really, if you really study the history of human nature, there's no revolutions. They're just mile markers where things changed that were notable, and nothing we did was crazy revolutionary. It was just, okay, let's go to this step. Well, that worked out well. Then, okay, let's get rid of this step, and that worked out well.
Yeah. So 2009. You do this series of open OLLIFs. When did you move to do that truly without the initial opening, all from the lateral? The surgery that I observed in your surgical room. When did you start doing that surgery?
Probably mid 2009.
2009. Okay, so pretty soon. Yeah.
Well, I mean, not that that's a brave thing or a brilliant thing. It's more, it was so obvious that it was safe and reproducible and effective. And I think the biggest comfort that I had was learning how to do an MIS TLIF very efficiently from, let's say, the not ideal trajectory angle. And so I immediately felt very comfortable once I had that skill set that I'm going to try doing things this way. And if I cannot do it, I can bail that patient out. And I can get the surgery done still in under 2 hours, and then, as obviously, it's always having that parachute, right? And then eventually you get rid of the parachute.
Exactly. Once you're comfortable, you get rid of unnecessary step. Now, let's say you did that. You said you did about 10 of that in 2009.
Yeah, early on. So we started talking about this, and it may have been even late 2007, but it was certainly in 2008. We started talking about this. 2009, the instruments were coming along. And of course, the instruments didn't arrive all at once. To your point about, talking to the engineers and taking stuff off the shelf and trying to see if we could just freelance it. The idea of like, how long do the wires need to be? Who cares? Just bend them, that kind of stuff. And so that happened relatively quickly. And a lot of that evolution was made possible by doing the kind of the hybrid open MIS and actually seeing, what I'm seeing on, like you said, I'm looking over here, right? What am I seeing on these two x-rays and what I'm feeling? And then I want to look inside and confirm that is what I think I'm doing. That happened pretty quickly. And because it was, relatively speaking, straightforward, the instruments came up pretty quickly. Ken deserves a lot of credit for that, for understanding not how to design a widget and not how to build a widget on a desk, but okay, I need a widget that'll do this, but in that hole over there, without me seeing it. And that's
he can do that. He told me because he has been scrubbing in with you a lot. That's what he told me.
I do commend him that he did. He scrubbed in, he watched, he understood the hurdles that we had, and took feedback on how do we make it. It may not be the best ideal engineering instrument in terms of the ideal rocket engine, right? But this is the fuel we have. We got to build an engine that works with this fuel. And a lot of engineers have a real hard time doing that. I've worked with really 6 major companies doing projects, and it is astounding to me how many engineers are brilliant, but they're only with what's right in front of them.
Yeah.
And Ken, to his credit, was willing to engage that and put the time in to think about it. And to your point earlier, there's a lot of after hours phone calls, a lot of weekend phone calls. You know,
did you keep going? What was your immediate results? What did you notice that is different after, I know you have the concept in your mind that this is less damage, patients are going to do better. What was your immediate results? What did you notice on patient side?
I think the first thing that hit me was these people are on their feet in 2 hours after the surgery.
Yes, that is what I noticed today.
And then we began to really appreciate all the pull through that comes with that, to the point now that it's pretty much standard. No matter what your surgery is, you're on your feet within 2 hours, even if you have to have somebody pick you up. And that was what hit me first, was these people are up and moving. And the second thing that hit me was their leg pain's gone, and I didn't ever see the nerve. I never cut anything away. Their back hurts, of course. We just, did a pretty aggressive reconstruction. But gosh, Hamid, I mean, I remember all the people that we would manipulate the nerves doing big laminectomies in neurosurgery, and their legs would burn for days, and they had all this phantom pain. That stuff that was gone. It was like doing an ACDF where the patient wakes up and goes, "My arm's not numb anymore, thank you." And so those two things, I think, were what I noticed first. And then, of course, once you realize it's helping people more than you expected, and then you realize it's efficient and quick and easy, and then that all is synergistic to make you want to do it more. Yeah. And then you add to that at the end of the day, once we started doing more than a handful, durotomies are gone, infections are gone. It's the stuff that's nightmarish for us.
So durotomy, for people who don't know, that is when we do surgery, we are very close to the very tough but thin sleeve around the nerves and spinal cord. Actually, it's called dura. And when we are doing regular surgery, there's obviously a risk that we can nick it, and then the fluid comes out. That adds significantly to the time of the surgery, complication of the surgery, and that risk is reported 7.8% in open surgeries with somebody who with redo scoliosis. That risk can jump up to 15-25%. That risk in my hand after 1,500 patients has been 0, because we are not there. So this is not a trivial thing. And to your point, that I notice still that my patient wake up and they tell me their leg pain is gone. Yes, they have back pain from the surgery. I can't tell you, that I'm still amazed. Every time I sit in the airplane, I'm amazed that it's just that big thing takes off and lands.
Right.
The sky. This is for me still amazing. This to a point that 2 months later, this is my very first patient I did OLLIF. And she goes on and explained that she was walking a few hours, as you said, after the surgery. But this is not what I was used to. I wasn't used to they walk right away. They go home so soon. They're back to their life so soon. I wasn't. It was so unbelievable for me that I knew if I cannot believe that, nobody else will believe that. So
absolutely, that's what I was just about to echo that sentiment, that until you see it, if you've only ever done open institutional-based surgery, you just don't believe it's possible.
Yeah. And this patient I have been following over the years. This is 3 months with testimonial. This is there's another testimonial of the same patient 8 months later, and then years later. And this is sustained result. By the way, 10 years later on this patient, I just last Friday, this is my very first OLLIF patient, I did the adjacent Zeckman disease, meaning 10 years later, the level next to that. And then some people say, what is your 10-year results? Well, this patient is 10 years older, another level goes bad.
Right.
So this was so amazing for me that I took time in my busy clinic and I started getting patient testimonials. Meanwhile, I have over 1,500 patient testimonials at different stages. They say they wake up, they could walk within an hour or two, they could go home. And if you just go to YouTube and put OLLIF, by the way, I just put OLLIF and Google, look at our podcast is already in there.
Already there.
It's already there. But but you can sit there and go down and scroll down, and then you start seeing my patient testimonials. These are all my patient testimonials. For 1 hour, I can just scroll down and see my patient testimonial that they say exactly what you said. They walk, the leg pain is gone, they return to work faster and better. So this is a tremendous pivot in the spine surgery that you have pioneered. But you just told me that you had that was amazing for you as well, that this patient. What else did you notice about this patient? I mean, there was a point that you decided you want to do it in a surgery center.
So I think I was going to say the how well they were doing. We were looking for just a safer, better way to do it, easier, quicker, less anesthesia, et cetera. And then we began to realize not only are we able to achieve the same goal quicker, we're actually getting a better goal and quicker. And that's the Reese's cup, right? That's chocolate and peanut butter came together. And then when did I decide we could do it in a surgery center? We were doing ACDFs already. We were doing MIS screws already. And there's a tremendous legal hurdle or a momentum in the United States of doing stuff like this in the surgery center. So I was nervous about doing it in the surgery center. I know Randy did it before I did in the surgery center successfully.
Dr. Bishop.
Yes, Randy Bishop. But to be honest with you, I did it in Mexico. We were guest surgeons down in the Mexican Spine Society. Mm-hmm. And we did, I think, 3 OLLIFs, and then realized they were going to send those people home the same day. And it was like this kind of epiphany of, well, if they can do it, why can't we do it? But my concern in the United States was not whether it's doable, it's what's the pushback and blowback going to be, if something goes wrong. Because you got to think about it from a institutional perspective. We have this surgery center, which is a very valuable asset that every time you do a surgery is at risk. And we have to have a transfer agreement with a major hospital. Mm-hmm. And so what if I'm doing this surgery and I get in trouble or I get in over my head or something's going wrong? Now I've got to transfer this patient. Well, that's going to be public, right? Mm-hmm. That's not. And so that's going to blow back on the surgery center, my partners, and not to mention medical legal.
And so all the surgeons that I want to emphasize that it is unfortunately not that truly academic and for the public good and so on. It's lots of egos involved there. Meaning that all the people who have a 7% risk of infection and have a morbidity up to the roof, all the people that they think it's okay to do a surgery that you do in 1 hour in 7 hours, they just need a reason to point a finger and say what you're doing is wrong. So
and now it's been over a decade and you post cases all the time and you get a lot of pushback. Do you get the same type of pushback, Dr. Talley?
I do. Yeah, I do. Let me start over. What you just said earlier, Hamid, about egos is the main issue. There's this idea that what I'm doing is best. And I guess everybody needs to believe that if you're a surgeon, that what you're doing is best. But there's also a blindness that comes along with that belief to stop actually asking the questions about, is a 7% infection rate really okay? Is a 3% durotomy rate really okay? And it's deemed okay because it's been accepted as the norm. And so what ends up happening, and that was the comment I was making earlier about with lateral being compared to ALIF, was here's the complications that you guys are having. They're terrible. Our complications are acceptable because that's the norm, but you've got this new complication that we can't tolerate.
Yeah.
And I'm looking at it the other way and going, okay, I'll take this new complication to not have that complication or that bleeding or that nerve damage or what have you. And that is an ongoing limitation to the development of more innovative surgery without question.
Yep. Well, I want to emphasize how important thing is what you just said, that we have to look at things in an overall kind of thing, not just one complication versus another. And I want people know that spine is not a rare disease that only a handful of people have. spine is not it's a public health issue. Spine is right now number 2 reason for disability in the United States, and the rest of the world wasn't among top 10 in 1990s, and in 2015 was number 4. Amanda, actually, we just looked up not long ago the number of the spinal fusions are performing in the United States. Amanda, what number did you find when you researched that?
1.6 million in the United States, but then I always want to say, like, that's just how many people did get the surgery, not how many people needed the surgery.
Right.
And so this, you and I are talking right now about the public health issue that may break our medical system if we don't have a better solution. Yes, we do this and that, but now the current system can just not continue that we put the patient a week in the hospital.
Right, for 4 days in the hospital with a complication rate. Yeah, sure.
Yeah.
And then, add to that when you start looking at what's the cost of that versus what's the metric that the public health and politicians measure, we're not measured. We don't do anything that shows up on those metrics. We don't lower blood pressure. We don't increase life expectancy. We don't, we don't decrease child mortality. We don't decrease, spontaneous miscarriages, et cetera. Mm-hmm. Those are the things that public health people focus on. We spend a lot of money making people's day better.
Yeah.
And,
lots of people's.
And dramatically better. And I'll give you probably the biggest thing I can say about that is I have had surgery. As I joke one time, I'm not just the president, I'm a patient of the Hair Club for Men. I was conservative on taking people to the operating room until I had my disc herniation in my neck. And that was indescribably awful 6 weeks. And when I woke up from my surgery and it was better, mm-hmm. It changed the way I practice medicine. I realized how devastating that pain is to people. It's very easy to minimize somebody else's pain because everybody has back pain. That's human nature. Everybody has back pain. And so when somebody has a real problem, we tend to measure it against, well, I've had that before. That wasn't so bad. Nerve pain's a whole different animal. It is a different animal.
By the time you're 70 years old, there's only 1 to 2% chance you don't have spine problem. Thanks God, we don't have surgery on all of them. But for many of our colleagues, and that's the fact, and I really appreciate that what you said. Once you went through the same thing, your perspective changed. I have back pain myself, where I cannot move an inch, and it happened to me every year once, maybe every 2 years once, that I cannot move an inch. So I know what back pain is, and telling to a patient like that, you just have to go and live with it because your surgery is not safe in my practice. And we tell that to lots of obese patients, to lots of elderly patients, that, you have to live with it. Yes, you have a problem, but surgery is way too risky. By the way, I don't want to go and learn new things.
Exactly.
Reduce the risks.
I don't want to do what makes me uncomfortable to get you from to help you not be uncomfortable.
Yes.
The crazy thing about, MIS in general, minimally invasive spinal surgery techniques in general, but specifically the OLLIF, is I don't really care how obese the patient is. Mm-hmm. As long as I can x-ray them, it's fine. Or how old they are, because my anesthesia time is going to be an hour at the most, and my blood loss is going to be 0. And in fact, we went through a phase where we were doing them with conscious sedation and local anesthetic, and that's doable. It's tricky, but it's doable.
You can do this surgery, and you just described a study that we did here in 2016. We took all the patients, about 388 patients from one hospital in 1 year, all the patients with fusion. And as you just described, that we talked about time under anesthesia, add to complexity, and so on. And for TLIF, that time goes up, obviously, when the obesity appears and BMI goes higher. The red is a STAR MIS TLIF surgeon, where after BMI of 37, because you have to work in a bigger hole, longer hole.
Are you working down this narrow little tube that it just gets longer?
And you just described, you don't really care. Look at green is OLLIF. With the higher BMI, the time of the surgery doesn't change, because you can help so many more people safely. And in another study, we collaborated and found the same results, that small steep thing is really statistically not significant. You can do the same safe surgery on the BMI of 20 or 45, whereas nobody else can do that. Now, you are in 2012, you are doing this surgery in a surgery center. You made a surgery that is really, nobody can imagine is a surgery center case. It's a hospital, 4 days hospital stay, 7 days hospital stay. You do it in a surgery center, but patients' well-being is not the only thing you have to consider. You have to consider the political landscape for you to provide that care. Now, what big of a group were you guys that performing this kind of surgery in 2012? And
you mean the number of surgeons that were actively doing it? Gosh, you'd have to ask Ken that. He would know more about that. I would say it was probably less than 50. It may not have even been anywhere near that. The problem we ran into is something you alluded to earlier, which is the ability to take two pieces of two-dimensional information, put it in the computer, and use my hands over here while I'm looking over there. And I grossly underestimated how big of a problem that was going to be. I was talking about how easy this is, how quick it is, how this makes sense. It's so straightforward. And we would bring people in as surgeons who, they functioned with their eyes and just they couldn't do it. And then they would just, we ran into a phase where people would try it, they would struggle, and then they would just say, well, that can't work. It's they find some reason that it's not their skill set that's the problem.
So, Will, I'm a little nerdy guy, you might have noticed. I make data about the data. I did interview lots of people who quit. Most of them quit between the case 5 and 7, and that is when they have the first patient to clinic. And the learning curve is steep. The learning curve, as a matter of fact,
very difficult.
Yeah, and especially if you haven't had that previous kind of training, this is the learning curve that I found out. Are you able to see that? You need 20 cases or 40 level in average to become really comfortable. But I tell everybody, with TLIF, PLIF, XLIF, ALIF is no different.
It's no different. It's just that you do it under somebody else's watch while you're a resident.
Yes, and as a matter of fact, I'm a private pilot. FAA requires you to have 20 takeoff and landing. This 20 seems to be our brain is wired that you need 20 exposure. You just have to make sure that 20 landing and takeoffs are made safe. But what we do in medicine right now is that we bring people for a cadaver lab over the weekend, most of the time in Vegas, so they can have more fun outside than inside of the lab, and then send them back and hope things go well. This is what I noticed. Only few exceptional people with a lot of previous training can go through that lab and come back and do it. But 95% of the people who I interviewed gave up after their between 5 and 7 case because they never made it at that level. They never made it there, and then they didn't, they weren't persistent or, like you.
And then I think the other part of that, Hamid, is you add to that, but they're not getting faster, they're not getting more efficient, they're still very uncomfortable.
Some people need longer,
And then, and then you get your first, for lack of a better term, I'm going to say complication, but your first patient that walks in complaining of something you're not used to, right? And that is, an amygdala response to that. I don't know what this is. I don't like it. I'm already nervous about the surgery. Now I've got this new complaint pattern that I'm not used to how it's going to play out. And so I'm out.
So you're a handful of very efficient surgeons making a surgery that's a hospital surgery in a surgery center. Tell me a little about your personal experience about how your environment received you, because I have the same. You have noticed I'm more vocal about it. And I get more heat probably than anybody.
Yeah, well, I mean, that's a
experience.
skill set that I wish I had. I don't advocate very well, and you're doing a great job of that with things like this, and I commend you for that. Even to some degree, the corporate sponsorship has dropped off, and you've picked up with that beautifully to try to keep this procedure going. I feel a little bit guilty that I didn't help you more along the way. But yeah, it's massive pushback. It's any and everyone who's got an axe to grind about MIS or they've had a bad complication. It's so very easy to throw a dart, and after a while you get kind of tired of being the target to some degree.
It's grinding.
It is. It's death by 1,000 lashes, right? It's not the one. It's the little the little continued negative pushback instead of what I would think in my kind of, I guess, idealistic mind is, I'm going to engage this and I'm going to listen to what you have to say. And then if it's better, I'm going to stick with it. If it's not, I'm going to help you understand or help myself understand why it's not better. But that's not what we ran into. What we ran into is just that can't work. And you're a bad person and you're doing crazy stuff and then you've heard it, you're experimenting on patients and
the sky is green because no amount of evidence, a picture of the sky is not good enough. Taking their hand, showing the sky is not good enough. Sky is green, no matter. Don't introduce
facts and logic into my argument.
Yes, exactly. I can give you a good news though, two good news. I was with a surgeon who would advertise himself and be proud of being maximally invasive surgeon. A surgeon who would be proud that he can do this 12-hour surgery with a massive opening and so on and so forth. That surgeon in 2016 converted after 5 years, after 2016, 2017, after he watched for 4.5-5 years, that it really makes an impact on patients' outcome. And he thanked me 3 years after he joined us that said, Hamid, I cannot really thank you enough. It is 3:00. I haven't done with all my cases, and 2 of them are going to be discharged today, so I don't have to round on them a whole week. I would be until 8:00 in the OR. And by the way, I don't have to round until next week because of the hospital, because they are going home. For 5 years, he fighting me, he thanked me for this transition. So eventually, I think the truth has its own way to establish itself. And this is, we are in medicine, we are conservative for a reason. We, as you said, this works. Why should I change? I know what the complication profile of this is. I stick with that. But you know what one of the biggest point for this transition was in my office is that people would come and ask to be seen by me. Yes. Patients have taken it in their own hand now. And people like Amanda did like this podcast. This is where I decided we have to go to public. We have to go to the patient because that is the grandma of somebody
that's the way around that institutional mentality. The institutional mentality is a self-fulfilling prophecy or self-fulfilling argument because the surgeon you're using as your example there, his honor, identity, his red badge of courage is, I do these massive surgeries. I have 2-liter blood loss, and I'm not a hand surgeon. I'm not taking out gallbladders. By God, I'm doing complicated life and death stuff. And then here comes guys like you and I going, well, you don't really have to do that if you do this.
Yeah.
And they don't like that. That's unpalatable. And I think what the industry has helped with is making this argument that MIS TLIF is a more difficult surgery to do technically, but it's easier on the patient. So you don't get this, because patients love to tell you they were in the OR for 12 hours because it tells you how bad things were. Right?
Yes.
It must have been awful because it took him 2 days to do my surgery. And
then here you go and do a 1-hour surgery. The problem goes away, but they don't see that the peak of an iceberg, what is underneath.
Yes.
Do that surgery in an hour and make the pain go away. Yeah.
But we're supposed to be, as surgeons, we're supposed to be satisfied that we did a complicated task and made it look easy. But it's such a human nature to want that feather, or, that accolade of, man, I did this complicated surgery and you just about died, and we saved your life 3 times, and look how great you're doing now.
Yeah. Whereas if you don't even let them get to the point that they 3 times died,
Right.
that is should be the policy or status that we desire to be.
I think that's going to happen.
Macho.
I think as we get more and more efficient at data collection, we're going to have to at some point acknowledge that Surgeon A's TLIF is not the same as Surgeon B's TLIF is not the same as Surgeon C's TLIF. Just because it's the same surgery doesn't mean it was done as well and as efficiently. And as we start to gather that data, and some of the insurance companies are already doing that, you know, Humana has their gold star surgeons. The point being, things like OLLIF are going to gain more value because you don't get honored for doing a complicated surgery that is dramatic. You get honored for doing a complicated surgery that looks like it's no big deal.
Yes, that change of paradigm. Now, the second really good thing, that I think you and I should be proud of what we are doing is that the patient do appreciate what we are doing. Now,
they do. In
the last year, even with COVID, we grew 500% because patients compare what we are, and they understand that. And social media is a big deal. Information is available. I have this T-shirt. It says it has a Texas map on it, and that's practically we are expanding.
We got here as fast as we could.
We are expanding to Texas and multiple other states because we grew 500%. Where in COVID, people were attracting, we were hiring people. People understand once. People who don't have an axe to grind, when they compare that, for them is a no question. I'm going to give you a personal story. I gave this talk to the Blue Cross Blue Shield of Minnesota, and I give them a lot of credit. After they looked at the data, they asked us, how can we help? And even it goes more. Every patient has a personal story. The vice president for physician relationship, after looking at our data, put a stop on the mother-in-law surgery that was scheduled the week after that. They just stopped doing surgery and sent that patient to us to get the surgery done with the OLLIF. After they look at the actual data, that patient was scheduled, and there is not a single week I don't get the patient. Once they do a little research, they cancel their surgery open old-fashioned way. They come to us. And you can imagine that my environment is not very happy about that.
Yep. And then the darts start. Yep.
But I think we are getting to a point though that it is the amount of the evidence is mounting. It becomes ridiculous. Like if you trash talk Mother Teresa, the joke is on you.
Yeah, so exactly.
What happens?
I completely agree. And it's in our industry, it's probably the worst possible example of that because we're dealing with human life, we're dealing with human suffering. And so we are by design very slow to change, very conservative. That idea of first do no harm mentality, which I always tell the medical students, like, what does that mean? Because the first thing I'm going to do is stick a knife in this patient. So
no, sometimes do no harm, we take it a different way. We say do no harm to my own practice, meaning that pushing the patient away. Because inaction is not often, is not do no harm. Inaction meaning that patient, when we were giving this information to the Blue Cross Blue Shield, they have an actual statistic. Patient has spine problem, nobody fixed that, they become non-ambulatory, their cardiovascular system
everything
shut down, and then
Absolutely.
in a year, they have to pay $500,000 for a bypass because their cardiovascular system shut down. We are just pushing those risks away from our practice. We are not eliminating that. Often,
correct. I agree completely.
Sending the complication to somebody else's practice by us being inactive. Now you and I will live this but what is the future? What is the future for us in the spine? What is the future for you? First of all, I want to know because I'm expanding and so on in all the places with my good group, and you and I, we have been talking for last 10 years. But first of all, what do you see? What are you going to do based on the information you have now? How is your practice going to be? What are you going to do different? And as well, tell me, what do you think we in spine what is our future? What do you think?
I think those are related but separate. I think the future is going to be more and more of the reconstructive mentality as the first line procedures. Not after you've had your laminectomy that didn't work, after you've had your discectomy that didn't work, after you've had 6 years of opioids that didn't work. Let's just go fix the problem and be done with it. And that also requires a recognition that things like adjacent level disease are genetically driven, not surgical. That's not a surgery problem. That's a genetics problem. And I think as that pendulum shifts a little bit, fusion becomes a more attractive option. I think we've got to continue to drive the complications down across the whole industry, of which OLLIF is a huge part of that, so that it's easier to get definitive surgical treatment done as a first line therapy. Because it's easy to get it. This. I mean, it takes me a day and a half to get your laminectomy approved. It takes me a 2 weeks and an appeal and another 2 weeks to get your TLIF or your OLLIF approved. And so I think as we get more durable and can control costs better, we'll just see a bigger and bigger paradigm shift towards reconstructive surgery. And that's pretty much where my practice is. I don't do much destructive surgery anymore. I think the biggest thing I've learned from talking to you more and more is I gotta self-advocate more. We've been pretty busy, and then I as you know, I started racing professionally, and that kind of
Tell me about that. Tell me about your racing.
I made a huge mistake 5 years ago and went to the racetrack for the first time, and so now it's been 5 years, and I'm actually running a full season with IMSA this year. So we'll be running all 10 televised races across the country.
Wow.
It's been a pretty rapid whirlwind progression. It's a lot of fun.
Yeah.
Congratulations. That's super exciting.
Congratulations. Now,
yeah.
Many of us surgeons, we have some hobbies that are extraordinary, and you're a good example for that your mind needs action, your mind needs new things, your mind needs new horizons. But that is what as well make you good at being a surgeon. It's not enough for you to say, bullshit and move on. You want to see it, you want to make it better, and so on.
One of the coaches made a comment about that exact sentiment, that there's a large number of doctors that get into motorsports, and the majority of them are surgeons. And Andrew said, the difference between you guys and any other successful person that shows up is you guys have learned how to learn. And so that's what I've found in my hobbies have been in satisfying, fulfilling, is this idea of how do I push myself to get better, and whatever that is.
What do you drive?
With racing is that it's no different than surgery for me. It's chaos. You're focused right here, and it's a continuous risk benefit analysis, right? I mean, surgery, do I buzz that? Do I pull on it? Do I not pull on it? And you get that instant feedback.
What do you drive? What do you?
So I've driven several different things. The car this year, I got picked up by Honda as a factory supported driver.
Wow.
So we're working with LA Honda World Racing, and that'll be a Honda Civic TCR. It's about 385 horsepower.
Wow.
But I've done all the way up to GT3. My personal car is a 911 GT3 that I ran last year in Porsche Sprint Challenge, which is a national single make series.
Do you have a video, if you can forward it to us? We love to add it to this podcast as that one of those video sequence where you are doing your other I'll try to send it if you can, or we can maybe look it up, Amanda, and definitely we should add it.
For
some
sure.
Links to that on our web pages and our social media. We love to as well show that we are not only a surgeon. We have other hobbies and so on, and we love to share that with the entire world. Now, so tell me, when is your next race?
First race of the season will be the Daytona, for the 24 hours of Daytona, the Rolex.
Wow.
So we do the 4-hour support race that happens right before that.
Excellent.
That's my goal.
Exciting.
And my goal is to get into the WeatherTech series. It's just a matter of resources to get there. I think it's
So
doable.
as we're closing out, do you guys have any more tips that you want to give for any of the new surgeons that are starting to join the spine community?
I think the thing that I would say, and the thing I tell all the young surgeons, is it doesn't matter where you train. It matters how long you keep training. Keep learning, keep asking questions, keep looking, and don't let the day-to-day grind take over your sense of curiosity, because that sense of curiosity is what's going to make your patients better.
Definitely.
I couldn't say that in any better way. Learning never stops. That is my advice to any younger surgeon. Well, this has been truly a tremendous pleasure for me. And we were planning a half an hour, and we are 3 times that amount. You have a lot to say, and I have learned a lot about this history. And I think people will look back in 50 years and say that 2007, 2012 was where a major change happened in the treatment of a major disease in the human. And you have been crucial to that. Now, I will thank you at the bottom of my heart taking your time and joining this podcast. Do you have any closing remark? Well,
you've inspired me to go do more.
Thank you very much.
Your energy is contagious. I appreciate that.
Thank you very much. For Inspired Spine and for Essence Podcast, I'm Dr. Abbasi.
I'm Amanda Armagast.
And our guest is
William Talley.
Thank you.